to introduce my other colleague, our wonderful Dr. Natalie Organek. So Dr. Organek completed her neurology residency at Cleveland Clinic, and this was followed by a fellowship at Penn. Since joining Houston Methodist Hospital, she's taken on many educational and leadership roles. Her interests include medical education, revamping some of the medical protocols we have at Houston Methodist, and also managing complex vascular cases. So without further ado, Dr. Organek.
Good morning, everyone, and welcome to Methodist Hospital. Dr. Garg, Dr. Volpe, as the leaders of today's program, we really appreciate, and our stroke colleagues with whom we work very closely, we appreciate the opportunity to participate in today's opportunity for education. So today I'm going to talk about the update for the 2022 guidelines for the management of intracerebral hemorrhage. My goals today are that we, number one, just introduce that there was a new guideline put out in 2022. We're going to review what they call the top 10 take-home messages, and then we're going to do a brief review of some of the major studies that affected the guidelines and are referenced in the guidelines. So as I mentioned, these were published last year. They were published in Stroke, and these are the American Heart Association and American Stroke Association guidelines for the management of patients with spontaneous intracerebral hemorrhage. This is an update from the 2015 guidelines for the management of ICH. It's about 80 pages worth of guidelines, which I had the opportunity to read for all of you and then kind of summarize today. But nonetheless, we're going to really focus on those things that they felt were the top 10 things that they want you to know for the update. These guidelines just discuss spontaneous intracranial hemorrhage. They don't reference neoplasm-associated hemorrhage, aneurysmal, TBI, or AV malformations that cause intracerebral hemorrhage. Again, as I mentioned, they took these top 10 things and they said, these are the things that we want you to know from the guidelines. So that'll be our focus for today. But we're going to talk about a couple of others. As a practicing neurointensivist, I think there's a few that weren't included in the top 10 that we really should discuss. So for those of you who are not familiar with the guidelines, the way they do it is they break it up into basically 4 different sections. They start with either a question or a statement. They then discuss a grading of how strong and how good the evidence is, which we'll talk about in a second. They follow that with a detailed explanation for the recommendations that they're giving, and then they close by talking about things that we need to think about for the future. So in the grades, there's 2 different columns here. The first one is the class of recommendation, and that's on your left. The second one is the level of evidence, which is your quality recommendation on your right. When you talk about class of recommendation on this side, this is telling you how strong the recommendation is based on a lot of different professionals that come together to make these recommendations. You'll see we have a number of class 1 recommendations, absolutely, where the benefit really outweighs the risk. But you'll also see that we'll talk about some harm recommendations, which the risk definitely outweighs the benefit. So these are things we should really be thinking about reassessing our use of. As far as quality of evidence, it starts with level A, and I'll tell you, we won't talk about any level A evidence in the intracranial hemorrhage guidelines. We'll talk mostly about level B, non-randomized data, and level C, limited data, and that is because that's the data that we have in intracranial hemorrhage. And these level A evidence are based on meta-analyses of multiple randomized controlled trials, and unfortunately, we're not in that position in intracerebral hemorrhage management at this time. So this is the top 10 list. Number 1. The first thing that they talk about is just the importance of how the hospitals organize when it comes to the management of intracerebral hemorrhage. And the most important thing is that every single person involved in a patient's care has an important role. Whether this is the hospital that's really, really out in the region and far and has fewer resources, or whether you're at the tertiary quaternary hospital where all of the resources are, we all have a role when it comes to managing patients with intracranial hemorrhage. The important thing is to know when is it something I can manage with my limited resources, and when do I need to transfer to the referral centers. So the formal guideline, what the guideline focuses on is consider transferring to a healthcare facility which has both neurocritical care and neurosurgical capabilities. As I mentioned, all of these will have a class of recommendation score. This is the strongest, which is class 1, and the level of evidence score, which is C/limited data, And that's, again, because you can imagine it'll be difficult to have a randomized controlled trial to say everybody's going to stay at a certain hospital or everybody's going to come to the main campus. All right, so number 2 out of 10 talks about hematoma expansion. And what we know is that in the setting of intracerebral hemorrhage, when the hemorrhage gets worse, the patients do worse. And so we want to avoid that whenever possible. This recommendation specifically focuses on neuroimaging and how to approach neuroimaging in the setting of acute intracranial hemorrhage. So the first recommendation is just confirm the diagnosis. Make sure you know what you're treating so that you can initiate treatment for exactly what the pathology that you're treating. This can be either with CAT scan or with MRI. Remember, most significant intracerebral hemorrhages will be visualized on CAT scan, though some places do have hyperacute MRI protocols which can be helpful, but not necessarily necessary in the setting of acute intracranial hemorrhage. The next recommendation is about doing serial head CTs. And what they recommend is that you do serial head CTs for the first 24 hours to monitor for hematoma expansion. They don't specifically say how frequently you should be doing that, but just that you do serial imaging within the first 24 hours. And you can imagine generally we do about, within the first 6 hours, absolutely. Definitely within the first 24 hours, there's an additional image. There's no set time, but it kind of depends on how your patient's doing and how bad their bleed is. The next recommendation regarding imaging for acute intracranial hemorrhage is for patients who have low Glasgow coma scales and or ND, which in their recommendations is neurological deterioration. And again, what they recommend is serial head CT, whether it's the first 24 hours or not. If your patient's getting worse, make sure that you're trending imaging. By trending imaging, you can not only look for hematoma expansion, you can look for hydrocephalus, you can look for cerebral edema and brain herniation. And the last thing we're going to talk about in their imaging guidelines for hematoma expansion is how you can utilize CTA to give yourself an idea of the risk of hematoma expansion. And of course, you can use CTA to indicate that there's a persistent injury to the vessel, which may complicate your further ICH and your risk of hematoma expansion. So make sure you're thinking about how you might be able to use CTA in your acute intracranial hemorrhage patients. All right, so number 3 out of their top 10 looks at etiology of ICH. And in this recommendation, they're largely focusing on the vascular causes of intracerebral hemorrhage. Just a quick review for those of us who are not doing intracerebral hemorrhage management every day. When you think about etiology, one of the things you want to think about is what is the patient's age and what is the location of the bleed. So is it a superficial bleed or a cortical bleed versus is it a deep bleed? And then we want to be thinking about your need for vessel imaging, whether that's CT vessels, whether that's MR vessels, whether that's cerebral angiogram, and whether that's venous imaging. All right, so these are the guidelines, and as I said, age and location of the bleed are really important, and that really becomes important in the guidelines. So this first one talks about if you are less than 70 years old and you have a superficial bleed, you should be thinking about additional imaging. Additionally, if you are less than 45 years old and you have a deep bleed, again, you should be thinking about additional imaging. And then if you are between 45 to 70 years old and you do not have a history of hypertension, then you should be thinking about additional imaging for your patient. And it's another reminder to not only think about potentially arterial imaging for your patient, but venous imaging too. Because the way you manage a venous-related intracranial hemorrhage is a lot of times significantly different than how you're going to manage an arterial intracranial hemorrhage. The next recommendation over here is that if you have a patient with interventricular hemorrhage who does not have intracranial hemorrhage, you really should be thinking about cerebral angiogram, otherwise known as DSA or digital subtraction angiography in their recommendations. And then finally, if you find an abnormality on vessel imaging, you really should consider angiogram to consider further diagnosis versus treatment. All right, number 4 in their top 10 is about hypertension management in acute intracranial hemorrhage. And the biggest thing that we need to think about is limiting blood pressure variability. We want a nice constant goal. We don't want big swings in blood pressure. And what we found is that if you control blood pressure well, without major swings, we tend to have better outcomes. Less hematoma expansion, better functional outcomes. So the recommendation is that once your patient has an intracranial hemorrhage, you should start to manage blood pressure within the first 2 hours, and you should have your blood pressure at your goal 1 hour later. And that should make a lot of our heads spin, right? Because that's a lot different than your general recommendation for hypertensive emergency and urgency. But of course, this is bleeding in the brain. So your treatment should start within 2 hours, and you should be at your goal within 1 additional hour. They make recommendations about what your blood pressure should be. And the recommendation is that if your blood pressure, when your patient presents, is between 150 and 220 systolic, their recommendation is that you lower to a blood pressure goal of 140 systolic, with a range of 130 to 150. But there's a caveat, and that is that if your blood pressure is greater than 150, absolutely make sure that you're thinking about not lowering your blood pressure less than 130. The reason is, of course, if you have someone with a very high blood pressure and their brain is accustomed to the perfusion from that very high blood pressure, and suddenly you take out that perfusion, you're going to have neurologic sequelae. So just be careful. Blood pressure is greater than 150. Make sure you don't drop your blood pressure less than 130 systolics. And I talked about, we're going to mention some of the data from which these guidelines are derived. And I think it's important because in stroke we talk about the studies a lot. And just a review for everyone of kind of some of these studies that they reference in these guidelines. And when it comes to blood pressure management, probably the two biggest and the ones that they reference in these guidelines are Interact and Attack. They were both published in the New England Journal of Medicine, one in 2013, the other in 2019, and they both looked at blood pressure lowering in acute intracranial hemorrhage. So that's Interact and Attack. Number 5 of their top 10 things they want you to know from the 2020 revision of the guidelines is about anticoagulation reversal in intracerebral hemorrhage. And we're going to talk about a graph that's actually in the guidelines. So your patient starts with an intracranial hemorrhage. The most important thing is stop the anticoagulation. Your next steps depend on what kind of anticoagulation you're on. Is it your vitamin K antagonist, which is largely warfarin, dabigatran, the 10A inhibitors, or heparin? If it's your vitamin K antagonist, your INR is going to be important and changes your management a little bit. And importantly, don't forget about IV vitamin K. And I think importantly, it's intravenous vitamin K, not other forms of vitamin K. And in fact, if you get a patient who's been treated with other forms of vitamin K, you might want to think about the risks benefits of actually giving IV vitamin K to make sure that they get the benefit from the vitamin K. With the dabigatran and the 10A inhibitors, of course, your reversal is based on when the medication was last taken. You have to think about whether charcoal is an option or not. If you take dabigatran, the recommendation is for the monoclonal antibody, which can reverse the dabigatran. If you have it, give it. If you don't have access to this, then you can consider PCCs, and or remember in dabigatran, you can consider renal replacement therapy. For your 10A inhibitors, Endexa is the reversal. If you have it, give it. If you don't, think about PCC. And then finally, the heparins, both unfractionated and low molecular weight, can be reversed by protamine. Just keep in mind that unfractionated heparin is reversed by protamine just a little bit better than low molecular weight heparin. All right, so number 6 in their top 10 things they want you to know talks about a number of things that we do in the care of intracerebral hemorrhage, which is either don't have benefit or they can actually cause harm. So we'll talk about a number of these that are all included in this guideline. And these are platelet transfusion, seizure treatment, intracranial pressure monitoring, hyperosmolar therapy, and steroids. So we'll start with platelet transfusion. The big thing about platelet transfusion is be really careful that it can be associated with worse outcomes. So the general guideline is that, in general, avoid platelet transfusions in patients who were taking antiplatelets prior to their intracranial hemorrhage. But there's a few caveats. One of them, if the patient is going to acute neurosurgical intervention, then absolutely consider the risk versus benefits of giving platelets. But otherwise, be cognizant of the fact that you can actually it can be associated with worse outcomes. This is largely based on the PATCH trial, and this is the major reference that they have in this guideline. And this was published in the Lancet in 2016. And PATCH looked at platelet transfusion versus standard care in acute intracerebral hemorrhage associated with antiplatelet therapy. It was randomized open label phase 3. And I just want to point out two things. Number one, in their findings, they state the odds of death are dependent at 3 months were higher in the platelet transfusion group than in the standard group. And therefore, their recommendation, based on the patch data, is that platelet transfusion seems inferior to standard care for people taking antiplatelet therapy before intracerebral hemorrhage. Platelet transfusion cannot be recommended for indication in clinical practice. Again, it's okay to reconsider your risk versus benefit in someone going to acute neurosurgical intervention. Additionally, one of the things that's been brought up about the patch trial is, though this is called a platelet, an antiplatelet trial, most of the patients were largely on aspirin. So the way you think about non-aspirin antiplatelets might be a little bit different, and we just don't have the data on that. The next topic we're going to talk about is seizure treatment under the no benefit / harm category. And basically what they do in the recommendations is they break up seizure treatment into 3 different categories. Those in whom you're absolutely sure they're having a seizure, those in whom you're concerned they might be having a seizure, and those in whom you're just prophylaxing for seizures in the setting of acute intracranial hemorrhage. So the first group we'll talk about are those who are absolutely sure are having a seizure, whether that's EEG evidence of seizure or confirmed clinical seizure. And the recommendation for the guidelines is that you do treat when you are absolutely certain that you have a seizure in the setting of acute intracranial hemorrhage. The next group is that group in the middle where you think maybe it's possible they're having a seizure, but we're not sure. And this is a good time just to remind everyone, when someone has any kind of intracranial pathology, every abnormal movement is not necessarily a seizure. So if you have this group, just put them on EEG. They recommend continuous EEG for at least 24 hours in these guidelines, but they don't recommend necessarily just starting an anti-epileptic drug in this setting. And then the last one is this group that of prophylaxis for seizures in the setting of acute intracranial hemorrhage. And based on the data we have right now, there is no benefit to prophylaxing against seizures in the setting of acute intracranial hemorrhage. That said, I mentioned that they go through a lot of the details of the data, and what we know is that data is largely collected on some of the older anti-epileptic drugs. And so might something like Keppra, which is a lot newer and not well incorporated into that old data, might it give us a different outcome? We don't know right now. But based on the data we have, there's probably no benefit to prophylaxing intracerebral hemorrhage. The next thing we'll talk about in this list is intracranial pressure monitoring. And they talk about 2 different things. One is how you use intracranial pressure monitoring to address acute obstructive hydrocephalus, and the other is how you could use it to try to, as part of the entire picture you're going to use to manage your intracranial hemorrhage. So let's talk about the first one. If you have a patient who has intracerebral hemorrhage, especially with interventricular hemorrhage, and your patient's mental status is significantly worsening, and you have imaging which shows acute obstructive hydrocephalus with an intracerebral and interventricular hemorrhage, but that the hemorrhages don't exactly explain the worsening in the mental status, think about the possibility of acute hydrocephalus causing the worsening in the mental status. And this is an absolute emergency, and this is an indication for emergent placement of an external ventricular drain, otherwise known as an EVD, with which you can then monitor intracranial pressures. The next one is, how do we use intracranial pressure monitoring to help us in our management of in acute intracerebral hemorrhage if we're not certain whether a patient has high ICPs or not? Their recommendation is this: ICP monitoring and treatment might be considered to reduce mortality and improve outcomes. So what we know right now is we don't know if it's going to be helpful or not. So this is where we have to go back to your individual patient and say, will it help this specific patient? And absolutely, nobody dies with acute obstructive hydrocephalus and a CT which shows the hydrocephalus but not a bleed that doesn't explain your overall worsening. No one should die without a trial of an EVD because it's absolutely life-saving. The next topic included in the no benefit / harm topic is hyperosmolar therapy. And they look at 2 different types. One is early prophylaxis with hyperosmolar therapy, and the other is in response to known elevated intracranial pressures. So the first one is the early prophylactic hyperosmolar therapy, and they don't separate hypertonic saline and mannitol in this guideline. But what their recommendation is that prophylactic hyperosmolar therapy does not really change outcomes based on the data that we have. But in contrast, What we do know is that hyperosmolar therapy can be used in the setting of elevated ICPs to help you treat elevated ICPs, and this is largely done via bolus dosing. So it kind of goes back to where we were, a number of years ago, where hyperosmolar therapy is a bridge to somewhere. It's a bridge to the OR. Sometimes it's a bridge to respecting the patient's goals of care, for example. But just know, early prophylaxis probably doesn't change management or outcome, but bolus dosing does help document elevations in intracranial pressure. And the last one we'll talk about in this group is steroids. And they recommend that we do not use steroids in the setting of acute intracranial hemorrhage. The big thing is just to remember that there are multiple types of cerebral edema, and they respond to different things. So there's absolutely a role for steroids in some types of cerebral edema, but in the cerebral edema associated with acute intracranial hemorrhage, there's not actual benefit to treatment of that type of cerebral edema. I mentioned we're going to talk about one or two that are not actually in the top 10 guidelines, but when you do intracranial hemorrhage management every day, just things that are important to talk about and review with everyone. And probably the big one in this list is thromboprophylaxis. So the recommendation is either low dose unfractionated heparin or low molecular weight heparin, and then it's initiated 24 hours to 48 hours after ICH onset. So again, whether you use unfractionated low dose or low molecular weight low dose, doesn't matter, but use one of them, consider using one of them within the first 24 to 48 hours. All right, number 7 out of their top 10 is about using minimally invasive surgery for hematoma evacuation in the setting of acute intracranial hemorrhage. And the data, what we have so far, is showing us that we do have a reduction in mortality, but we haven't seen a lot of improvement in functional outcome. So when it comes to minimally invasive surgery in these situations, just know that all of the guidelines specifically discuss intracranial hemorrhages that are at least 20 to 30 mLs, and with people who have lower GCS scores, so 5 to 12, and of course your max is at 15. So what we know is minimally invasive surgery, it does probably reduce mortality compared to medical management alone. It is probably better than open cranie for functional outcome. We had a lot of data at one part and thought with open cranie, if we go in and just take that collection of blood out, we would lead to better outcomes, and we didn't really find that. We got the blood out, but the outcomes didn't change. But the thought is with minimally invasive surgery, maybe with a minimal approach, we'll do less damage going in, and maybe there's a benefit there. When it comes to minimally invasive surgery, they reference the MISTY trial. The MISTY trial was published in the Lancet in 2019. And MISTY is minimally invasive surgery with thrombolysis in intracerebral hemorrhage evacuation. It was randomized, controlled, and a phase 3 trial. Their recommendations at the end of the MISTY trial were this. For moderate to large intracerebral hemorrhage, MISTY did not improve the proportion of patients who achieved a good response 365 days after intracranial hemorrhage. The procedure was safely adopted by their sample of surgeons. I think those who are involved in the treatment of intracranial hemorrhage are still excited about the possibilities of minimally invasive surgery. Maybe we don't have all the answers yet, but is there something in the future? I think we all still look toward the possibility of this change in functional outcome in the future. All right, so we're on number 8 of 10, and this is about assigning DNR status to acute intracranial hemorrhage. And this idea of this self-fulfilling prophecy of poor outcome that we talk about in the management of these types of patients. So we'll circle back on that just a second, but let's talk about DNR status in acute ICH. The recommendations are, number 1, that in a patient who was not previously DNR, but there's discussion about DNR status, their recommendation is that you wait at least until the second full day of hospitalization to consider changing your patient to DNR. And why do they do that? And this is one of these harm recommendations. And that is because we know in these types of patients, once a patient is made DNR, they tend to have a worse outcome because they tend to get different management. So, and I think it's really important just to recognize that this is the issue, and sometimes that is because the ICH is so massive that the appropriate thing is to make someone DNR. But there's even some descriptions in their summaries that basically talk about patients that are made DNR in the setting of ICH sometimes don't even get thromboprophylaxis, for example. And of course, they aren't offered aggressive surgical interventions. Of course, there are going to be problems about taking a patient who's DNR to the OR. But I think the most important thing is just recognize once your patient's made DNR, that means do everything until the moment of cardiac arrest, or at least consider everything until the moment of cardiac arrest. Otherwise, your approach to treatment, your goals of care should be a little bit different. Number 9, and we're almost to the end now, is about rehab. Again, the focus in their guideline for rehab is about having a multidisciplinary team. The other important thing that they talk about is getting the patient out of the hospital early, getting the patient home early. And I thought it was one of the things that they talked about is just the importance of getting the patient back in their home environment and how there's no better incentive to really be aggressive in their rehab at that point than being back home and wanting to do what they could do before and maybe getting close to that or learning how to navigate their new deficits in their own environment. There's 2 important things I wanted to talk about in the rehab guidelines, and that is to talk about fluoxetine. Of course, there were some studies, not only on fluoxetine, but also on SSRIs, which they reference in the guidelines. And what we found is that fluoxetine doesn't change functional status post-stroke, but I think it's important to recognize that doesn't mean we shouldn't be addressing depression, because absolutely, that depression changes post-stroke functional status. And again, it's probably a multimodal approach, medication and other things. The other thing I wanted to mention is, again, this is another harm score, so where risk outweighs benefit, and that is very, very early mobilization. In the first 24 hours, aggressive mobilization probably leads to worse outcomes, so just be careful in the first 24 hours, but definitely move toward the rehab part of the pathology after that first 24 hours. And then the last, number 10 of the things you need to know from the 22 update of the ICH guidelines is really don't forget about the caregiver. You know, no one goes on a journey of intracranial hemorrhage on their own, right? This is all supported by us in the hospital at first, but it's the caregiver who becomes an extension of our team at home. So make sure we're thinking about the caregiver, make sure that person has physical, mental, social support, because they are going to be the primary caregiver of a person who has very different abilities than they had prior to their intracranial hemorrhage potentially. But quality of life is the most important, both for the patient and for the caregiver. So in closing, just to review the goals, number 1, I wanted to introduce the intracranial hemorrhage guidelines in the update in 2022. I wanted to review the top 10 take-home messages and just give a brief review of the studies that they reference based on these, which help them build these recommendations, and just a brief review on those. Thanks, everyone.